Good morning. We will start the Nestle symposium. Thank you so much. Please, if you can take a seat. So welcome to this symposium. It's time to start. We're a little bit late, and we have lots of work to do today. My name is Florian Scotté. I'm a medical oncologist in France at Gustave Roussy, and also the MASCC president, the current MASCC president, because we change every 2 years. It's a privilege to be with you. Thank you so much, Daniela, for Nestle Group to support us, to support MASCC, and also to give us the opportunity to have that symposium this morning, because we will discuss the important topic of nutrition. So the title of the symposium is Advancing Nutritional Care in Oncology, Precision and Multidisciplinary Approaches. And we have a huge speaker in the presence of Professor Carla Prado. Carla is a distinguished university professor and a Canada Research Chair in Integrative Nutrition, Body Composition, and Energy Metabolism. Wow. So we just wait now for your talk about nutrition, and then after I will give a talk about multidisciplinary approach in order to try to cover the nutrition aspect in the management of our patients. The floor is yours.
Thank you so much. Thank you, everyone. Thank you for coming. I'm going to put my timer here. So first, I'd like to thank Nestle for the invitation. This is, so we're going to talk a little bit about nutrition. I have an overview, going to give you an overview of the importance of nutrition, also focusing on muscle. These are my disclosures related to speaking engagements and advisory board participation, which have not influenced the content of my presentation. And I wasn't here yesterday, unfortunately, but I heard that you've talked about malnutrition, and we all know that malnutrition is very prevalent, and it's not only related to cachexia, is a widespread condition across tumor types and tumor stages, as you can see here. And within malnutrition, so malnutrition itself or as a separate condition, we know that muscle wasting or muscle loss is a primary nutritional problem experienced by patients with cancer. And this is the result of a meta-analysis that showed the prevalence of low muscle mass in patients with solid tumors. And you can see here that, first of all, it's not, let me see if my mouse works. Can you see the mouse or no? Can you see the arrow or no if I point? So then I'll just use the pointer. Here. On. There we go. There we go. So you can see here that it's prevalent across cancer types, so similarly to what I've talked about in malnutrition. And it's not only the palliative setting, but also the curative setting. So a prevalence of 30%, and it can obviously go higher in the palliative setting. Now, you can see that even in cancer types that are not as catabolic, like breast cancer, we still see a prevalence of 30% muscle wasting. And that is severe muscle wasting. It's not just like lower than normal. So it's a severe, severely low amount of muscle. And we know that this muscle wasting in patients begin even before cancer is diagnosed. We know cytokines are being produced by the tumor that leads to an accelerated catabolism, and then cancer treatment, as well as like surgery, chemotherapy, radiotherapy are all related to catabolism. So the loss of muscle mass increases according to tumor progression, and it can certainly worsen with cancer treatment. And this is some data that we haven't published yet, just highlighting how rapid muscle loss. Feel free to take pictures, just please don't post on social media if you go on social media, because we may change with some ongoing analysis. But what we see here is a very rapid loss of muscle at the beginning. So when patients are diagnosed with cancer, there is some stability, probably related to controlling tumor symptom and management control as well in the medium term. But then, a long term, even into survivorship, we're still observing a decline, substantial declines in muscle mass. And this is in gynecological cancer, but this is also highlighting the importance of continuing intervention, because the decline of muscle can track into survivorship, which is very important. And one thing that it's important for us also to remember is that weight stability can mask muscle wasting. So this is some data that we've worked on with almost 2,000 patients with early stage colorectal cancer. So again, we're not talking about palliative setting. And 53% of these patients were weight stable. Now, despite this body weight stability, 1 in 8 developed low muscle mass, over 10 months, or 15 months, sorry, and 1 in 7 developed myosciatosis, so worse muscle composition. And this was associated with a 40% higher relative risk of death, independent of changes in body weight. Now, another characteristic of this loss of muscle is that it is very high, especially compared to aging. So here we have the percentage of muscle loss per year with aging, and then in selected cancer types. And what we see here is that the loss of muscle mass in cancer can be 24 times greater than that observed in aging. And actually, 100 days of cancer treatment equals approximately 20 years of aging in terms of loss of muscle mass. So that is certainly substantial, and we now have hundreds of articles highlighting how low muscle mass is an independent predictor of outcomes. These are the results of another systematic review. Similarly to my previous message, you can see how prevalent that is. There's also some sex disparities that are observed similarly to what we see in aging. But what the literature show us, if just some selected examples, is that low muscle mass is an independent predictor of post-op complications, survival. There is also risk of falls, and chemotherapy toxicity. Now, chemotherapy toxicity is something that has fascinated me for many years because most chemotherapy agents are administered based on body surface area. And as you all know, body surface area only takes height and weight into account. So if you have two individuals who have the same height, the same weight, but very different body compositions, they'll still be receiving the same amount of chemotherapy because their body surface area is the same. So the hypothesis has been that the person with a lower muscle and consequently lower lean mass compartment would be receiving a very large amount of chemotherapy based on a small amount of muscle and therefore a lean tissue compartment. And therefore, this person will be at greater risk for dose-limiting toxicity, which is absolutely, as you know, undesirable, leading to dose delays, reductions, treatment termination, hospitalization, and death. And now we are really beyond the proof of concept that the prevalence of those limiting toxicity is higher in people with low muscle mass. So these are a combination of different studies published separate individually, different cancer types, different treatment types. So really moving beyond the proof of concept. But nothing has been done other than these associations up until last week. So there was a paper that came out last week. That's the first paper ever that has looked at dose escalation study based on lean mass. So again, lean mass is the compartment of the body that has muscle, very important component, but also organ mass. And what they've done is they looked at colorectal cancer, stage 3, and they looked at oxaliplatin treatment. So they've had one group, so the normal muscle group who received the BSA-based dose, and this group was not randomized. It was just for them to compare it later. And then they randomized patients with low muscle mass into the BSA-based dose and the lean mass dose. So here, they've given chemotherapy based on 3.09 milligrams of oxaliplatin per kilogram lean mass. Where does this number come from? Come from a previous study from the same group that showed that people who received higher amount than this number per kilogram lean mass presented with severe toxicity. So they've done this randomized controlled trial, and their primary outcome was to prevent grade 2 or higher neurotoxicity during the first 6 cycles, so about 3 months of adjuvant oxaliplatin-based chemotherapy. So this is what happens, and this is the type of study that we've been waiting for more than 10 years now in the field of body composition and cancer toxicity. So now they've looked at the proportion of patients without grade 2 or higher neurotoxicity for, again, this first 6 cycles. And you can see here in orange, we have the group who received the lean mass adjusted chemotherapy versus the BSA-based chemotherapy. So what they found was that there was a 47% lower risk of developing significant neurotoxicity for the lean mass adjusted chemotherapy group. So that's substantial. And they've also shown that this grade 2 or higher neurotoxicity, so that's how they've defined those limiting toxicity, favored the lean mass-based dosing in terms of neurotoxicity-free survival. So on top here, we have the lean mass-based dosing compared to the standard BSA dosing. So that is pretty interesting. They've also found that there was a longer time to grade 2 or greater toxicity onset for the body composition-based group, a higher cumulative dose without toxicity, as well as fewer dose reductions. Now, quality of life was also better for people who were dosed based on body composition. So here we can see the scores in red. We have the group who received the BSA-based compared to blue who received the body composition-based, and lean mass-based dosing reduced patient-reported neuropathy symptoms over time. Now, importantly, to avoid any criticism, excuse me, they've also looked at safety, and lean mass-based dosing is safe. There was no compromise in relapse-free or overall survival. So it improved tolerability without sacrificing efficacy. This is a game changer. And as a dietitian, I obviously am going to have to bring it back home, because now I wanted to take that into account, turn that around, and conceive as what can we do then in terms of toxicity and improved overall outcomes for our patients if we can target this loss of muscle, halt this loss of muscle with nutrition intervention. Now, a lot of people are skeptical about the importance of nutrition, because on one side, the orange side here, you can see that the loss of muscle in cancer is multifactorial. There are so many factors that are leading to this muscle wasting, but also what we have to remember is that nutrition, the quantity and the quality of nutrients, is essential to sustain muscle. So obviously we need optimal nutrition to fuel the muscle so that we can halt this process, and as part obviously of a multimodal intervention. So I'm going to show you some selected examples in the literature to show the importance of that. So here we have data from the EFFORT trial. So this is a secondary data analysis of this massive trial that really was also a game changer in nutrition. In the blue box, I'm not going to read all of that, but we see the type of interventions that these patients received. So it's targeted nutrition. So just looking at how can we meet patients' needs using different strategies. And what they found was that people who received this targeted nutrition intervention, they lived longer. And not only they lived longer, but they've also shown an improvement in quality of life, as well as a decreased risk of functional decline. Now, remember that I've mentioned, just going to drink some water here, recovering from a cold. The pathway and how muscle wasting is a continuum. And I usually like to use the analogy that it's like a wildfire. Our patients lose a lot of muscle at the beginning. It takes much longer for us to restore that muscle than the amount of time that it took for them to lose. So early and continuing intervention is absolutely essential. This is a study that actually looked at early intervention. So these are patients with head and neck cancer, and what they've done is they've started nutrition intervention the first week of treatment. You know they're going to be losing weight and losing muscle, so let's just hit the ground running here. And what they found, so you can see they've used dietary counseling with or without oral nutritional supplements or medical food. You can see that what was included in the ONS. I'm going to use the term ONS for oral nutritional supplements. Overall, you can see the difference in weight loss. So the nutrition intervention group lost less weight. And if you only look at the nutrition intervention group, so again, patients who received this intervention, you can see here at the start of treatment in blue, the end of radiation therapy in orange, and then in gray you have 3 months after. So again, the continuum of treatment, you see that body weight was fairly stable, energy intake and protein intake, as well as quality of life and grip strength, which is a marker of muscle health, were fairly stable. So they were able to overall maintain it, not worsen. So they've concluded that early intervention in this study, specifically at the start of radiation therapy, resulted in better weight, maintenance, as well as increased protein calorie intake and improved quality of life. They've also looked at the percentage of those reductions or suspension, both for people receiving radiation or systemic therapy here, and they've compared the group who received only counseling versus counseling and or nutritional supplements. So again, the use of ONS reduced the need for changes in scheduled anti-cancer treatment. So less prevalence here of those reductions or suspensions, going back to the chemotherapy toxicity that we've talked about before. Okay, is everyone still awake? Okay, great. I'm usually like to make more noise, so you guys are very quiet, so don't worry, I'm not gonna be singing my karaoke's if you heard about it. Now, I would love to present this study. As my dear friend Jill says, I've started this study as an assistant professor. I'm a full professor with all these titles now, and I just finished the study. So it took my entire career almost to, have you done RCTs in oncology? Welcome to my world. But I was very proud to talk about this study, and we have a lot of actually new data that we're working on now, omics data, so stay tuned for more. But the PRIME study looked at protein requirements in patients with cancer. I heard you presented that before, heard that before yesterday. And PRIME was a 12-week randomized controlled trial, and we were testing the feasibility of 2 intakes of protein. The lowest recommended, 1 gram per kilogram per day, versus a dose that they've asked us to study, 2 grams per kilogram per day, because we really don't know if there is any benefit of 2 different doses of protein. So we worked with colorectal cancer, stages 2, 3, and 4, non-cachectic, and patients were capable of oral nutrition, so no problems with that. And the data that we're going to look at in terms of intake was based on measured, so we did weighted food records here. So what happened in the trial? So the first question, the primary outcome of this pilot study was looking if whether it's feasible to achieve a higher protein intake. And as a dietitian, I was like, I'm going to try to do that through food first. Probably one of the biggest mistakes of my life. No, that's not the biggest, but I'm joking. But here you can see protein intake in grams per kilogram per day. Now the dotted lines on the top and the bottom here, so purple and green, were the destination, where we wanted our patients to be. So the 2 gram group was supposed to be here, the 1 gram group was supposed to be here. Now this is what happened. The 1 gram per kilogram per day patients in that group got excited with the study. They thought it's a nutrition study, protein should be good for me, so they decided to eat more. And we were not even close, even with intense nutritional counseling, of achieving the 2 grams per kilogram per day. So I started this study hoping to find 1 gram difference between groups, and I ended with 0.4. So what did we learn? First of all, if you think about the pattern of change that I've mentioned before, we expect protein intake to go down. Now, we actually were able to improve protein intake, which is actually, they were just starting chemotherapy. This is a pretty good data showing that individualized nutrition counseling positively impacted protein intake. However, the approach that we used to achieve a higher protein diet during cancer treatment was very challenging. We're not able to achieve that through food alone. Now, I'm going to show you some preliminary data that our recommendations, like 1 gram, 1.2, 2 grams, are mostly based on expert opinion. They're not based on mechanistic studies. So we're actually doing the very first study that are looking truly at protein requirements of patients with cancer. And we use a technique called indicator amino acid oxidation. I'm not going to have time to explain all of that, but what I wanted to show you is just some preliminary findings, although it's very unlikely that this data is going to change. And what we're seeing for patients with early stage colorectal cancer in this study is that their requirements is around 2 grams per kilogram per day at the time of active cancer treatment. It looks like it goes down later, spoiled alert, 1.5, but still higher than what we're reaching for here. And if that's true, if they need 2 grams per kilogram per day, you've just seen data from my other studies, how difficult that is to achieve. We're going to have to change our approach here to how we're going to be counseling these patients. Now, parenthesis closed for this preliminary data. I'm going to show you now what happened to muscle mass in the PRIME study. We've looked at appendicular skeletal muscle, so that's a surrogate assessment of muscle because it's from muscles from arms and legs. And we were not powered to see differences in muscle. So just let's be fair here with the data. However, look at the pattern. You can see here that when we expect that to go down, these patients actually maintain or even increase. There's a pattern of increasing, I'm going to say the word muscle to be simpler here. So look at the p-value. When you get that analysis, you'll be like, oh, almost. But let's be fair. I did not have the power. But that's pretty interesting, and it shows a response to nutrition intervention. In fact, if you lump everyone together, because my 1 gram group messed my study up by eating more protein, we do secondary analysis when that's the case in RCTs. So what we've seen here is that for every 1 gram per kilogram per day increase in protein intake was associated with a 1.6% change in muscle, which is physiologically meaningful. And in the Q&A, we can talk a little bit more about what actually hinders that increase, obviously inflammation. Okay, parentheses closed for that study. Now, we also published a meta-analysis recently looking at higher protein intake for patients with cancer, how beneficial that is. And here we've seen that 10 grams or more of protein per serving was associated with a positive increase in weight as well as muscle. So there was a decrease in muscle loss. We've seen improvements in muscle strength as well as improvements in physical performance. Now, to wrap it up, I know that you've probably heard that before, but we have to achieve this higher protein intake, prevent malnutrition while dealing with very important nutrition impact symptoms or gastrointestinal symptoms that are preventing our patients from eating. So what do we do? So this study, just showed that throughout the trajectory of cancer, we have to deal with difficulty in adherence. We can use strategies such as oral nutritional supplements to improve adherence for our patients. So this study here was looking at adherence to ONS by energy density, and it's difficult to see here, but just to summarize, what they found was the higher energy dense or nutritional supplements resulted in greater adherence. So it's easier for patients to adhere to that. They're getting more for their bucket, right? So it's easier for us to achieve energy and protein requirements. You do improve adherence also when you offer a wide variety of flavors. Just think of our diet. If we have more to choose from, it's certainly better for adherence. And higher adherence is also achieved with low volume, high energy ONS. So certainly easier for patients to be achieving their needs. So in conclusion, muscle loss is a major yet under-recognized threat to treatment tolerance, recovery, and survival. Early and individualized nutrition intervention is key to preventing and reversing this muscle loss. Higher energy and protein intake significantly improve outcomes. Adherence obviously matters and can boost the intake of ONS. Protein needs are high, especially during active cancer treatment, so our job is really to meet them. And I would just like to conclude by using an analogy. As you know, I love to use analogies. I have a 7-year-old girl, so this is my life. And I actually used that with patients before, and that's pretty interesting, because what we have to do, thinking of this entire trajectory, is to conceptualize nutrition intervention as a road trip, so they have to start prepared and make regular stops. So early intervention, it's a long road ahead. It's like really starting with the full tank of gas and a well-maintained car, but then also making the continuous stops. Remember how low we can go even after cancer, like after they finish treatment, muscle can decrease. So making these regular stops to fuel, check the tires, and make sure the car is still in good shape, really avoiding this muscle breakdown along the way. Thank you so very much for your attention.
Thank you very much, Carla, for this very interesting talk. Okay, that's perfect. So it's my turn. I'm a medical oncologist. I'm absolutely not a nutritionist. So if you have specific questions, we will ask them to Carla. But the purpose of my talk will be to more explain the role of multidisciplinary approach and the role of medical oncologists in the early assessment journey of the patients. So my conflicts of interest. Just to remind you, Carla has mentioned many outcomes related to malnutrition to our patients specifically, but we also have impact on healthcare system. As you can see on that slide, there are different studies that are impacts on length of stay, there's an impact in mortality, so in patients with unplanned visits to the emergency room, blah, 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 blah. It means that it has an impact on the healthcare system. We have to avoid these different impacts. You are attending a MASCC meeting, so obviously I have to highlight the nutritional study group. So thank you to Tataki to be here. We have a very active study group in that field with a very huge collaboration between different countries. We have CASC, CHASC effort, and it's huge to have these efforts globally. Is the role of MASCC, and if you work only in your center, you will have results, but very small results. If we are able to share our information, to share our skills, it's in that situation that we can support better our patients. So we know that we have an evolution today of the patient's journey in cancer. Previously, we had patients in a curative intent, so they received their anti-cancer treatment, and at the end, they were cured. Okay, perfect. And now we are having more and more patients in that situation. After treatment, it's blurred. So we need to be involved more and more in survivorship. It's a role of MASCC also. We also had, obviously, the bad prognosis journey with patients receiving an anti-cancer treatment and then having a palliative care setting, and after the end, we have to manage our caregivers. But now, more and more patients are receiving treatment in the long term. So they receive treatments with toxicities. They will have an impact on their journey. They will have an impact on the different outcomes. And in the long term, we have to manage sequelae, but also toxicities, and malnutrition is an obvious, very important topic, because if we don't manage it correctly, we will have patients with more toxicities, for example, neurological toxicities, and it will be difficult in the long term to maintain the anti-cancer treatment. So you obviously know that that slide. It was a very interesting study. It has been presented at MASCC 10 years ago in Denmark, in Copenhagen. It was a reflect of an interesting study developed in colorectal cancer. We know that patients receiving pre-habilitation are getting a better health status. So when they receive their treatment, the health status will fall. And at the end of treatment, if they receive rehabilitation, they can have a health status after treatment better than before having the diagnosis of cancer. It's the role of pre-habilitation, rehabilitation, so physical activity, but also nutrition management. We have guidelines from ESMO, for example, which is interesting because in that paper they can differentiate the care the management that we have to provide to our patients in a bad prognosis and patients with a very good prognosis, depending the number of weeks, months, years that the patient will have in front of him, and then the adaptation of the treatment of the management in the different situations. So we know that we have several grade of recommendations, level of evidence, and you have them on that slide. So we have organization of care, we have management structures, we also have drugs, nutritional supplements, obviously, and we also have new drugs. So I will not go to the new drug, but we have today ongoing new drugs development, very interesting in that field. So now I will move more deeper in details. In France. So in France, we're lucky to have a clear definition of supportive care, which, as you can see on the slide, includes nutritional management of our patients. So it's mandatory in France to have this management of patients in every institution with the authorization of anti-cancer treatment. You also can see that in the complementary supportive care, we have physical activity. So the combination between physical activity and nutritional management is probably the core of the management of our patients, and I will show you after what we do at Gustave Roussy specifically. So the Nutrition Day, these are the results from 2023. We will have in October the Nutrition Day 2025, and the results are always delayed between the different years. So these are the results 2 years ago. As you can see, 50% of our patients are malnourished. 50%. One of 2 patients are malnourished. It means that we need to develop the nutritional management of our patients. At Gustave Roussy, the best anti-cancer institution of the world, I'm sure that you agree. Thank you to say yes. As you can see on that side, we have exactly the same result. 50% of our patients are malnourished when they start the treatment, when they receive the anti-cancer treatment. So we have to improve our management, and it's the interest of the Nutrition Day is to have a clear picture of what you do in one day, in 1 week, in your institution, and how you can make the development of a better management of the patients. So, for example, a very simple thing: do you weight your patients at the admission in the hospital? As you can see, only 60% of patients are weighed at the beginning. It's crazy, but it's reality. So it's something very simple that we have to improve. And that cycle is really interesting. You first have to screen your patients. So first of all, weight at the admission and weight regularly. Then we have to diagnose and assess the situation of the nutrition or malnutrition of your patients. You can provide a nutrition plan in the situation of the patients with a bad situation. Then you give nutrition treatment. You monitor after, and at the end, you go back to the screening during the anti-cancer journey. So this study was really interesting because we had the vision from physicians, but we can also have the vision of patients. And as you can see on the slide, patients want to be aware of nutrition, but they are not. They are expecting from us to give them informations, to give them education on how to be better managed. A very dramatic point is that 40% of patients reported having a severe weight loss. Okay. Among these 40% of patients, only 45% of them will receive oral supplements. Wow. And among that, 30% because my doctor prescribed them. Okay, fantastic. 15% because I asked for this prescription. It means that we need to educate our patients. Supportive care are always coming from patients. Unfortunately, not from professionals. So if we all educate our patients, they will go to the medical oncologist consultation, they will go to the surgeon consultation, that they will ask they will complain for receiving supportive care. And then we will be able to develop more supportive care efforts. So the purpose of my talk is multidisciplinary, and we had that publication which group all the different approaches that we can have around our patients in cancer care. And as you can see, we have the approach of nurses, obviously, dietitians, nutritionists, but also psychologists who are really important. We also have exercise activity specialists who are really important also. The general practitioner, the nurse at home, the pharmacist are all the people really important around the patient in order to have the patient-centered care and delivering the best treatment. It's the situation for nutritional disorders. It's also the situation in general for patients in the context of cancer care. So this is a real patient receiving an anti-cancer treatment, an old patient, and the message is that we have to ask the question, to include the patient in the decision that we provide. Does the patient need a feed tube? Yes, no. Okay, we discuss all together. We have the decision. Do we assess the feeling of the patients? Maybe not systematically. That's something that we should do. So at Gustave Roussy, I give you these informations. We did an assessment, a retrospective assessment 3 years ago, in what are the expectations, the needs of patients and the management of our patients that we were able to provide. As you can see, nutrition is the major topic that we have in our institution, and I'm sure that is the major topic that we all have in our hospitals. As you can see, we have pain, social workers, psycho-oncology, physiotherapists. Also interesting, but nutrition is the major item. So the objective was to develop a new approach of the patient journey in order to better assess his situation in nutrition, but also in the other settings. So we tried to assess at the different steps. The first step, obviously, is diagnosis. So we assess the situation during treatment and after treatment. And we organized the monitoring and the management of patients depending these different needs assessment. So we have developed this vulnerability questionnaire, which is in 9 domains, and we have different scoring related to that questionnaire. It's a self-assessment. So we ask the patient, like in the PRO programs, we ask the patient if he has symptoms, if he has lack of autonomy, if he has different disorders. And for elderly patients, we also give the G8 questionnaire. So, excuse me, the process is that one. For every new patient, we address the questionnaire before the first meeting with the medical oncologist or surgeon or radiotherapist. So the patient will self-assess the situation, and the objective is to organize the supportive care management before the first meeting, before the first consultation. Then we no more have to wait for the medical oncologist to give the warning of, hey, he has lost 10 kilograms, you have to come in my room. Okay, I have a patient to see, yes, but it's really, it's an emergency for that patient. He has lost 10 kilograms. Okay, couldn't you call me before when he lost 2 kilograms? Because I could maybe give better solutions. Okay, so it's the reason why we have developed that early assessment of patients joined to the anti-cancer journey of anti-cancer treatment journey of our patients. So the patient is at home, really quiet. He receives the questionnaire with wives, with husband, with pharmacist, with GP on the phone, and then he can reply to the different questions. And at the end, it's combined in our digital platform. And depending the score, if the score is at 0, there's no warning, so the patient will receive just information. If there's a score at 1, so he will be driven to one specific consultation, for example, dietitian or psycho-oncologist. And if the score is above 2, then it means that the situation is complex. So we probably have autonomy plus malnutrition combined in the warnings, and then we drive the patient to the day hospital in order to have a better assessment. The assessment is provided by one physician, one nurse, and usually we combine one dietitian and one physical activity educator in order to assess autonomy and the nutritional status. So this is a specific score that we have for diet. As you can see, we ask for the height, but also the weight and the loss of weight and the kinetic of this weight evolution, but also the oral intake assessment. So do you eat correctly or not? Do you like to eat or not? Do you eat with the mouth or not? So do you have a tube already or not? And then depending this algorithm, we decide if there's a warning or not. And I present you the poster that I will present tomorrow morning. It's the assessment of our patients. The objective of that trial, of the development of the early assessment and the personalized supportive care journey that we provide to our patients, was to avoid decrease of quality of life, as I have presented to you in the prehabilitation and rehabilitation slide. And we met the objective, as there was no decrease in quality of life at 3 months and 6 months after starting the treatment. So at Gustave Roussy, specifically, what is the organization for nutritional management? As you can see, the population of the department included in the patient pathway division is 5 physicians, 16 dietitians. Yes, we are lucky to have so many dietitians and to have physicians involved in nutrition, but we also have nurses and administratives. The structure is one inpatient unit with 12 beds, one box, one room for one-stop day, 2 rooms for consultations, and 1 mobile team. The activities are always obviously about education, clinics, and research. And we have now fast-track programs, as you probably have in your institutions, for patients with lung cancer, with GI cancers, and so on. And I present you the decision tree that we have. So we have the systematic approach for every patient, as I mentioned, the day hospital, the one-stop day. So if there's a problem in terms of malnutrition or autonomy, we drive the patient to the nutrition one-stop day. And then the patient will receive a very specific and global approach with the nutrition team, with Diana Cardenas, your friend, and Bruno Henard. In the case of the patient has an emergency, When he goes to the fast track and he has lost many kilograms, and the surgeon or the oncologist say, oh, we cannot wait for 1 week for having this global assessment. We need to have a huge assessment today because we have the consultation. So we drive the patient to the nutrition one-stop day, and eventually the patient will be driven to the inpatient unit. When the patient will go to the nutrition one-stop day, he will have different assessments using calorimetry, impedancemetry, and so on. So there's a very specific approach of its management. And at the end of the treatment, we also need to assess the situation of the patient and provide for rehabilitation, but also simply for after treatment to give monitoring, but also a personalized pathway. And it's what we do with, again, an assessment with dietitians, nutritionists, physical activity educators, and so on. So thank you very much. Just to remind you what Matti mentioned yesterday in another session, supportive care makes excellent cancer care possible. This is the MASCC message. We are here not only to give quality of life, but to give years to our patients in better quantity, but also better quality of life. Thank you so much, and welcome to Melbourne next year. Okay, and this is the Q&A section now. We have 1 minute.
I was going to say briefly, this importance of patient education is so, like I've mentioned, the karaoke. Like we've done brochures, free cookbooks, and the karaoke is like parody karaoke, like lean on meat when you're not strong, just call on protein when you need a hand. We all need nutrition to lean on. But anyways, patients. I'll never get invited again. But I was just gonna say this is. Oh my goodness! I'm just gonna say this is wonderful for patients, and we need to quantify that. But people get the message, and when we have physicians, especially the oncologists, telling them about the importance of nutrition is even more like relevant. I'll let you guys ask the question. Sorry.
What a question! Thank you. You've both alluded to the need for more protein, more energy in this patient population. I find that oral nutrition support in the upper GI and like hepatobiliary patient group is really difficult, no matter what you do. Whether it's low volume, high calorie, high protein, it's very difficult. Do we have a bigger place for enteral nutrition? And if so, how do we find a way for that to be more acceptable, not only to patients, but actually to physicians to have better conversations?
Oh, I think that we do need to reassess our guidelines and reassess the evidence that led to the guidelines we have nowadays. So much have evolved. So the answer is probably yes. I would say it's going to be country specific, but with, especially when we can get it, like, I think there is enough evidence, Kate, that we think we should be doing it, but guidelines are based on evidence. And that's where we get stuck. And then physician education is another part of the game, right? If I had more time, I would specifically talk about some experiences that we have had where patients were following the diet until the physician's like, well, why are you doing that? They stopped completely. So physician education is one thing, but I think we need to relook. But we're looking forward to the new oncology guidelines. I am hoping that's going to be a little bit more evidence in terms of enteral nutrition and the space for that. But I'm not sure what's being discussed and what's going to be in the new ones. But I certainly agree with you.
Thank you for a great presentation and song. I'll have to take that back. I have a question about energy balance and protein intake. And I've always read the protein articles with extreme interest and certainly understand it, but I have never really seen, or at least I don't remember, people evaluating the adequacy of energy intake simultaneously with protein intake. And have you ever done that in your projects? And have you ever stratified your analyses? And I ask, and I'll let you
Go ahead, Kim.
I ask because I think we as nutrition experts know the need for adequate energy intake along with protein intake. I don't know that message is being translated to our colleagues. And I think about some of my colleagues in exercise oncology who are cheerleaders for getting enough protein intake, but not thinking about also getting enough energy intake. And it's so easy when you're looking at like protein powders separate from ONS to get lots of protein and not enough
And
calories.
I also blame the prevalence of obesity among our patient population. So then people don't think energy is important, right? But if you don't give enough energy, where is protein going to go to? 101 physiology, right?
Right.
So it's not going to go to build muscle, that's for sure. So have we done that? Yes, with PRIME study, they were all energy balanced. I didn't have time to say that. But we were actually the first to put people in a whole body colorimetry unit. And so we have that data now, and we're looking at the change over time. So this is a whole room where people spend 24 hours. The last study that was done was 25 years ago with 5 people only. So we've done it with more than 30 people. So this is like you have everything, total basal exercise, energy expenditure. So we're looking at a lot of studies. So we're thinking in the same direction because I do think energy is neglected. And you know what's happening? We are overall, just roughly going to show you some of the data. It's like, I'll tell you some of the summary data we have is that first, it's all over the place. So our recommendations are saying, give them normal caloric intake because some have high, some have low. But overall, we're seeing that we are underestimating caloric needs. So that's exactly what we're saying. I even get chills. I need to get a life. But we are underestimating their energy needs. So that what's happening? So they're not reaching that level of protein, right, to begin with. And exercise and nutrition are totally divorced. That's another thing for us to discuss. But the bottom line is we have a lot of those, if you guys are on LinkedIn, things like that. We post those studies there when they're out. We have some new studies coming out with double labeled water as well. So free living, not only confined, but if it's confined and we're still seeing an underestimation, so that's going to be, the magnitude of that is going to be expanded. So the bottom line is, yes, we should be looking at energy. Should we be measuring energy in everybody? I don't believe so, but we should be deciding which patients will benefit the most from assessment. We're also doing some studies on bedside techniques, and they don't seem to be as good. Our equations are also not hitting, right, like home for most of our patients. So I think we have to use critical reasoning in our care of our patients and see which patients will benefit from an assessment, a better assessment of their energy needs.
Thank you very much. Very quick question. Wonderful presentation. I just wanted to ask, is in Edmonton, are oncologists using the lean body mass as to calculate, or
Good
we are
question,
still...
right? Dr. Michael Sawyer is, so he was my postdoc supervisor. Now I boss him around. I'm joking. Don't tell him that. Jokes apart, what they do is a lot of our physicians, because of the research being done there, they look at the images, and it's sometimes you don't quantify it, but it's so obvious, and they automatically dose reduce patients. You know, the same way as you have a person with obesity, you're going to scale down, and cap the dose. That's what they're doing. But that's almost like, again, based on critical reasoning versus a number or evidence-based number. I really think that study that came out last week is going to be the game changer for us. Like, it's really, now everyone needs to know about body composition. So, we can be maybe having to stratify people based on body composition. So BSA was established by dogma, right? So we know that. And it was the best way to decrease interpatient variability in drug distribution and metabolism. But now, so how can we do better? And if lean mass, especially for hydrophilic drugs, is the way to go, everyone here next year is going to have to, you're going to have a symposium on body composition within your meeting.
Yes,
So.
next October in Bistro.
Thank you.
Okay, thank you very much, Carla.
Thank
Thanks
you, everyone.
to all of you and Nestle for this report. Very, very important. Thanks for the skills that we have shared this morning. So I just have one message. Please join the study group, the nutrition study group of MASCC. The second message, because I have another one, is please take your flying ticket now to go to Melbourne next year at the end of June. And the third one, please join the General Assembly now somewhere in the hotel. Thank you very much for your attention.